Good day, Mamleen. My name is Joanne Marie Negro, and my video presentation is all about Meckel's diverticulum. Meckel's diverticulum is a congenital pouch-like outpouching of the small intestine, specifically in the ileum, resulting from incomplete obliteration of the vitelline duct during fetal development. And for the etiology, according to my research here, it actually occurs when the vitelline duct, which connects the yolk sac and the midgut in the embryo, fails to fully close and disappear by 7th week of gestation. Meaning, by that time when the fetus is 7 weeks of gestation, it was expected to fully close, but in this case, it's not closed. So when the fetus grow up and become a kid, his intestine would look like this. So that's red, yellow is the skin, and that's the intestine with a Meckel's diverticulum. Now for Meckel's diverticulum, it actually happened 2% out of 2% of the population. So imagine having 100 people, so there are 2 out of 100, and then imagine 1,000 people, there could be 20. But what about 1 million people? Meckel's diverticulum does not really have any subtypes, but here are the name of the complication that is related to Meckel's diverticulum. First, the persistent vitelline duct from ileum to umbilicus is a fully patent duct connecting ileum to umbilicus. Second, the vitelline duct cyst is actually cystic remnant with both ends closed. Next, the vitelline sinus or umbilical sinus polyp, persistent opening or tract near the umbilicus. And then D, here's the Meckel diverticulum. And then the last one will be the vitelline cord or band, fibrous cord, solid remnant from ileum to umbilicus. So, common risk for this is when it is more common in boys than in girls, so males. And also if there's like a history or familial history or genetic history of Meckel's diverticulum. And then lastly is that if there are other congenital problems that could contribute to this, such as hernia, something like that. So here is the pathophysiology of Meckel's diverticulum. But before we dig deeper, let's focus on the predisposing factor, which is the males. The sex has history of Meckel's diverticulum and has other congenital problems. Apart from that, I also include in the etiology or the causes is actually regarding to embryological origin. During fetal development, the vitelline duct, as I mentioned earlier, connects the yolk sac to the midgut to supply nutrition. So it obliterates by the 5th to 7 weeks of gestation, but in this case it fails, did not enclose or did not obliterate completely. So that's what I mentioned earlier. Now, what are the anatomical characteristics of Meckel's diverticulum? So it's located at the anti-menestric border of the ileum, about 2 feet, like 60 centimeters from the ileocecal valve. That another anatomical characteristic is that it should be true diverticulum containing all layers of the intestinal wall, such as the mucosa, submucosa, the muscularis, and then the serosa. Now, usually about 2 inches or 5 cm long. Always remember the rule of 2s, okay? The rule of 2s. So that's gonna be 2% of the population, as I mentioned earlier, 2 inches long, 2 feet from ileocecal valve, and 2 types of ectopic tissues. Now, talking about ectopic tissues, that's going to be part of our pathophysiology, often contains heterotrophic tissues, most commonly gastric mucosa, and sometimes pancreatic tissues. Ectopic gastric tissue secretes acid, which can cause ulceration of adjacent ileal mucosa, leading to a painless lower GI bleeding, especially in children. Now, part of the pathophysiology would be potential complications. What are the potential complications? Well, we have bleeding due to ulceration from acid secretion of ectopic gastric mucosa as part of our ectopic tissues. And we also have obstruction can cause intussusception, volvulus, or act as a lead point of bowel obstruction. And we also have diverticulosis. Inflammation can mimic appendicitis, and also perforation, rare but possible, especially when ulceration is severe. So diverticulitis as the third part of potential complication, as I mentioned, it could mimic appendicitis. It could they could feel pain, something like that. Now, as the last part of our pathophysiology, we have clinical manifestation linked to pathophysiology. The manifestation would be painless rectal bleeding, most common in children, signs of bowel obstruction, abdominal pain, vomiting, and distension. And there's also signs of peritonitis if perforation occurs. And there's also symptoms that can mimic appendicitis. So basically just the same as the potential complication, but this part is a manifestation or something that you could expect. So in addition to the manifestation that I give out, specifically for assessment findings, patient would also experience painless rectal bleeding. That's one. But if the Meckel's diverticulum would try to mimic appendicitis, of course there will be pain in that. So there will be intermittent abdominal pain. There's also fatigue or weakness, and dizziness or faintness. So those two latter manifestation are actually call out for a hypovolemic shock. Of course, you would lose a lot of blood in this Meckel's diverticulum through rectal or through your anus. So if there's like a lot of blood loss, so you will be expected to experience a hypovolemic shock. Now, apart from that subjective findings, there's also objective findings wherein there will be like a visible rectal bleeding or blood-stained stool, bright red or maroon in color, and also pallor due to anemia from chronic or acute bleeding. Abdominal tenderness, there's also going to be an abdominal distension, possible if bowel obstruction is noted. And also signs of shock like tachycardia, hypertension, weak pulse, just the signs of hypovolemic shock. There's also positive fecal occult blood test and possible palpable mass. Laboratory procedures that would rule out Meckel's diverticulum. Technetium 99M scan or Meckel scan detects ectopic gastric mucosa. And for other assessments, you can also have CBC to check for anemia, especially for a patient who is experiencing blood loss or heavy blood loss. Ultrasound or CT scan may help as well. For therapeutic management, we have two types of management that we can actually provide to a patient experiencing Meckel's diverticulum. So for medical management, we can stabilize bleeding. That's really the most important one. We can stabilize bleeding via IV fluids. So of course, if there's a heavy bleeding due to Meckel's diverticulum that was lost through the rectum of the patient, we can do IV fluid and BT or blood transfusion. We can also provide medication that are proton pump inhibitors or H2 blockers for acid. And the last one or the other one is the surgical management, wherein the definitive treatment is diverticulectomy or bowel resection if it's complicated. And of course, if there's medical and surgical management, there's also nursing management. So for nurses, I am to monitor vital signs for bleeding or shocks, assess for anemia, prepare for tests, pre-op NPO and IV fluids must be closely monitored in post-op wound care, pain management, monitor bowel function, and prevent infection. So that's definitely the things that I am to observe in caring for a patient with Meckel's diverticulum. So what are the rationales for those? So to monitor vitals for bleeding, of course. Again, for bleeding patient, it's really necessary to closely monitor or assess for hypovolemic shock. Again, because say for example a patient is experiencing a heavy blood loss, then of course it would signal the brain that, oh, there's no enough blood that's getting somewhere on the upper extremities of the body. So your heart would keep on pumping so hard just to compensate compensate what's been missing, or the oxygen that's not been delivered to the upper extremities, because there's no blood to deliver because it was lost due to excessive bleeding. So yeah, those are the things that you could assess. And then after pumping, but then again there's no blood and polycythemia cannot compensate, then your heart would eventually stop pumping. So that's hypovolemic shock for you. And of course NPO, closely monitored pre-op, okay, because it's really dangerous to have someone eat on their way pre-operatively for any type of surgical or operation that is invasive. They should not eat.